This presentation will review the pain assessment and hit on reporting abnormal findings. Your learning objectives include being able to assess for the presence of pain as that fifth vital sign using the cold spot technique, differentiate between the different types of pain assessment tools, and report abnormal findings. Looking at our concepts, we have pain and comfort as a concept and the pain assessment as the exemplar under that concept, and the concept of teamwork and interprofessional collaboration, and then the exemplar is reporting abnormal findings. So here are two definitions of what pain is. Pain is an unpleasant sensory and emotional experience, which we primarily associate with tissue damage or describe in terms of such damage or both. And then my favorite is pain is whatever the person says it is. You will get a lot more detailed information on this in PathoPharm and Wellness One, but I wanted to touch on the different pain categories so that we as nurses can identify what type of pain it is so that it can help us assess them better, right? So again, look at these slides in terms of what we need in order to assess pain in our clients. So pain is categorized either by duration or by origin. This slide compares the two different pain's duration category. So you're looking at acute pain. Acute pain is basically typically it's associated with an injury. It is protective and temporary. What I mean by protective is the body, let's say your hand is on a stove, a hot stove, and your body is identifying it's in pain. So your brain tells it to pull your hand away. So this acute pain is trying to protect the body, protect yourself. It's usually associated with a recent injury, and once that injury is treated, the problem is treated, and the tissue starts to heal, that pain will go away, as opposed to chronic pain. What I really want you to pay attention to on these next couple slides are what is the patient going to look like when they're having pain. So in acute pain, the patient's heart rate's going to go up, which is called tachycardia. Their blood pressure is going to go up, hypertension. They're probably going to be anxious. They might have some sweating or diaphoresis and muscle tension. Behaviorally, they will typically grimace, moan, cry out. If you're palpating or percussing the part of the injury, they're either going to flinch, pull away, maybe guard the area because they don't want you to touch it, or it's hurting them when they move. And again, once you treat that problem, that pain will go away. As opposed to chronic pain. Chronic pain is not protective. It's ongoing or recurs frequently. Usually it's lasting longer than 6 months, and it persists after that tissue healing has taken place. With people that have chronic pain, a lot of times their vital signs will not vary. You won't see it like you do in acute pain. Not that you don't, but sometimes physiologic responses in chronic pain, you don't usually see an alteration in vital signs. But what you will see typically is when people have chronic pain, you will be able to assess fatigue, decreased level of functioning. They're not able to do what they could do in the past. They can't do their ADLs, their activities of daily living. They may be depressed. And the psychosocial implications of that can lead to a big time disability and an issue with this chronic pain. And often management is aimed at relieving the symptoms that they're feeling. Then you have pain categories based on the origin or where that pain is coming from. So in nociceptive pain, that pain arises from damage or inflammation to the tissues. The second bullet is important when you go to assess a client that's in pain. Remember, we're going to assess them, asking them to describe their pain. And when they describe it as throbbing, aching, and localized, it should clue us in our head that, this is a nociceptive pain. The origin is nociceptive. It can be somatic, which means it's in the bones, joints, muscles, skin, or connective tissue. It can be visceral, which is internal organs. So like if somebody has had surgery on their intestines, let's say, that's a visceral pain, and oftentimes they have pain that is referred. So oftentimes when I took care of patients postoperatively that have had abdominal surgery, they would complain of pain in their shoulder. So that was referred pain. And cutaneous is that third subcategory of nociceptive pain, and that is pain that's in the skin or subcutaneous tissue. As opposed to neuropathic pain, which neuropathic pain arises from damaged nerves. Okay, so pain that's caused by nerve inflammation, damage to the nerves. And the patients, when you ask them to describe their pain in this situation, it'll be shooting, burning. It kind of feels like pins and needles. And I have a first-hand account on this. I've had back surgery and I've had damage to the nerves from my spinal column, and I would complain that I had pain, shooting pain or burning pain down my leg because of that nerve, the inflammation to that nerve. Another type of neuropathic pain is also considered phantom pain. So this is pain that is described as oftentimes patients who have had an amputation will have pain still in that leg or in that area where the leg has been amputated, or in diabetic neuropathy, so that their feet, they have nerve pain in their feet or their extremities. These physiologic responses to pain are, I took from your textbook on page 43. And these are responses that we should pay attention to as nurses when we're assessing for pain, when we're doing our pain assessment. People that are in pain oftentimes are afraid, they're anxious, they might feel hopeless or have trouble sleeping, and they might have thoughts of suicide. They oftentimes can have decrease in cognitive function, mental confusion. Sometimes they will have their pupils will dilate. Again, like we talked about in the last slide, they can have an increased heart rate, increased respiratory rate, which is tachycardia, tachypnea, and hypertension. They might have perspiration, which is diaphoresis, muscle spasm, to the point where they might, if they're in so much pain, I don't know if you've ever had a pain where it's kind of thrown you to the floor, or you've had difficulty standing because of that pain. And that's that physiologic response to the pain. The experience of pain is highly complex. We talked a little bit about the physiologic responses, but there's a lot more to it than that. The book talks about 7 dimensions of pain. And there's a assessment guide on page 147, it's guide 9.1, that looks at all 7 of these dimensions and gives you as nurses some suggestions on things to ask when you're doing that nursing interview or collecting that subjective data. Things such as, so if you're looking at the physical dimension, which refers to the patient's perception of pain and how the body is reacting to it, you may ask them questions like, what surgery or medical procedures have you had? When you're looking at the sensory dimension, sensory concerns with the quality of pain and how severe it is. You'll see this in our mnemonic cold spa, which we're going to look at in the next slide. But you ask them, where is the pain? Where are you feeling it? On a scale of 0 to 10, how can you rate your pain? As far as the behavioral dimension, behavioral refers to those verbal and nonverbal behaviors that the patient may demonstrate. Again, we talked about that in data collection. So you might say to them, I notice you're holding your side or your abdomen. Are you having pain? Sociocultural dimension is a little bit it's a little less harder to assess, I would say, and it's the sociocultural concerns are impacted by a patient's cultural background and how they may view pain. Okay, so you need to ask in order to get to that dimension of your pain assessment. Do you have any spiritual, cultural, or social practices that may influence your health care? Cognitive dimension is looking at, again, a patient's beliefs, attitudes, and intentions, motivations related to pain and how we manage it. So what do you think's causing your pain? In the affective dimension, you're looking at their feelings and emotions that are related to this pain experience. So you may ask the question, how does the pain affect your daily life, or how does it affect your mood? And then lastly, the dimension, the spiritual dimension. And remember, we talked in the very first week, we talked about how your holistic assessment, nursing assessment, includes the mind, body, and spirit. So we want to make sure that we are paying attention to any type of religious or spiritual beliefs that may impact the client's health. Get very comfortable with this mnemonic, this cold spa mnemonic. It is a way that you are going to use to assess your client pain. So when you ask your client, do you have pain? And he or she says yes, then you will go through these questions. Can you describe your pain? Is it stabbing, deep, or dull? That's character. Onset, when did the pain begin? Location, where is the pain located? D is for duration, how long does it last? S, oftentimes students will go right for the S, and you don't have to do it in this particular order, but S is a really good severity. It's a really good question to ask so that you can quantify what that pain looks like. So on a scale of 0 to 10, where 0 is no pain and 10 is the worst pain ever, what number would you give it? How would you rate it? Then P is for pattern. What makes the pain better? What makes the pain worse? This is a great question because it can help you in your interventions and how you're going to help the client. And then lastly, A is for associated factors, or how it affects the client. So what other symptoms occur with it? How does it affect you? And these are great questions and things that you will need to be very comfortable and familiar with. I have another slide that is a picture from your book on the next slide that goes into the cold spa mnemonic. This is taken right from your book on page 22. Box 2.4 gives you some other questions, some other way to evaluate or assess the client's pain. So pain scales are very good tools, if you will, because there's several different pain scales, but they're very good tools that allow us as nurses to assess our clients and be able to objectify, if you will, or get to, remember, pain is a subjective data point. It is what the patient says it is, okay? But we need to use reliable and valid tools so that we can assess them appropriately. So here on this slide, I talk and give you pictures of a couple different pain scales. You don't need to memorize all of them, but what I do need for you to know is that these are valid and reliable tools, and we will use a pain assessment tool and be consistent on that tool when we're assessing someone's pain. I oftentimes use the FACES pain scale in pediatrics. We very often use the numeric pain intensity score, so on a scale of 0 to 10, 0 being no pain at all, 10 being the worst. But there are some situations where, which in a couple slides I'll talk more about, which these pain scales are not able to be used. But in majority-wise, you'll be able to use these pain scales, one of these pain scales, to assess your patient's pain. So in every assessment that we're going to be doing, we're going to be looking at what we've covered so far, collecting subjective data, objective data, validating and documenting the data, and then analyzing it. So let's focus in on the pain assessment and collecting subjective data. Very important, as we talked about previously, that in order to get good information from your client in your client interview or your health history, you want to maintain a quiet and calm environment that's comfortable for the patient or client that's being interviewed. You absolutely want to maintain their privacy and ensure them confidentiality. Ask the question in an open-ended format. Tell me about your pain. You might ask first, are you having pain? Yes. Okay, tell me about your pain. But then you want to use those active listening skills we talked about on week 1 to carefully evaluate the client's description of what they're saying their pain is like, and quote them. Use quote marks when you are documenting what the subjective data is that you have collected. Client says she has pain in her right leg, whatever it is. I'm just throwing that out there. Watch for the client's facial expressions and grimacing during the interview. Remember, those are those behavioral responses and part of that general survey. Do not, absolutely, this is huge, do not put words in the client's mouth. So don't answer for them. You need to use your active listening and let the client explain to you what the pain feels like, when it started, all your questions through the cold spa, but make sure it's in the client's own words. Very important to ask clients about past experiences with pain. This gets to that cultural and spiritual and even behavioral dimension on how they react to pain, what they believe, what their beliefs and values are about pain. And then again, believe the client's expression of pain. Anything the client says is to be, the pain is what the client says it is what I'm trying to get at. We just reviewed collecting subjective data. Now let's look at objective data. So you're going to look at that general impression, that general survey, inspection, observe their posture, observe any facial expressions or grimacing, inspect joints and muscles if that's where their pain is, or observe for any scars, rashes, any changes in discoloration. And then obtain their vital signs. The 3 vital signs here, remember we talked about physiologic responses to pain, tachycardia, tachypnea, and hypertension. You're going to want to monitor those vital signs and be able to assess it appropriately and analyze it appropriately. So some clients may be unable to self-report pain. Clients such as cognitively impaired clients, elders with dementia, unconscious clients that are intubated or have a breathing tube in, infants or pre-verbal toddlers. These are all examples of clients that are unable to self-report pain. So for nonverbal persons or those that are cognitively impaired, it's been recommended that we use this hierarchy of pain assessment techniques. And there are 5 items, and you go down appropriately. Okay, so you attempt first to collect data from the client, self-report from the client. But if they're unable to do that, then you go to the next step. You identify any kind of physiologic conditions or pathologic conditions or common problems or procedures that they may have had. So you're searching for the cause of the pain. Then the next step is you're observing the client's behavior. So you're looking to see if they are grimacing. You're looking to see if they have they're guarding. You're observing their behavior. Surrogate reporting. What this means is you can use family members, caregivers, someone that knows the client to ask if that patient, that client, loved one is in pain. And then lastly, you can attempt an analgesic trial so that you may give them some Tylenol, you might give them Motrin, you might give them some type of analgesic and see if that changes their behavior and helps them in the pain, helps relieve their pain. Again, these are a couple points that I want to make before we get into validating and documenting. The most critical aspect of pain assessment is that it be done on a regular basis and you use a standard format like those pain scales, the FACEs, the numeric scales. You believe you listen to the client and you know that pain is whatever the client says it is. Another big important point is that you need to reassess your patient after each intervention to evaluate whether what you did made a difference. Did you, when you adjusted the leg on a pillow, when you elevated it, did that help? Did that improve the patient's pain? When you medicated them, did that improve their pain? So there are several interventions that we can do to modify the client's pain. But when you are assessing, when you're doing a pain assessment, you want to assess and then reassess after each intervention because you want to see if your intervention was effective. And if it wasn't, then you're going to modify and do something different. And then the time frame for reassessment should really be directed by what the patient needs and or your hospital or unit policies. Inpatient rules will vary depending on where you are working, but typically when you medicate for pain, you will have to go back in and reassess within that hour, and you will need to document and show that you have reassessed for pain. So in this pain assessment that we've been discussing this whole presentation, you have just collected subjective data, you've collected objective data. Now you need to validate that data and document. And you need to validate the pain assessment data you've collected with the client. Sometimes you may have to validate that with a caregiver or a family member, depending on what their dimensions, their cultural or their spiritual attitude towards pain is. They may not want to express it, but then you want to document the assessment data appropriately. And like we talked about in the last slide, the most important thing is to make sure that you are documenting on a reliable and valid tool, and you're documenting after any type of intervention and according to your agency's policy. So whether that's every hour, every 2 hours, whatever that may be. Okay, so everything that we do with assessments from here on out, I want you to remember the ADPI, the nursing process. So after you've collected your assessment data and you've identified abnormal findings, you're analyzing that data. I want you to think about clustering that data and trying to determine what you do next with that, right? So there's, again, 3 different ways you can go. You can create nursing diagnoses that are things that we can do with nursing interventions, and then there's collaborative problems, which are the problems that they differ. Remember that, and I didn't do a great job at explaining this before. So your collaborative problems differ from your nursing diagnoses in that they cannot be prevented by nursing interventions. Okay. These complications can be monitored and detected by the nurses, and they should be. So you need to monitor for these complications, but you'll use interventions, both dependent interventions that are prescribed by the healthcare provider and independent nursing interventions that you will do within your scope to try to minimize the complications of the problems. And then the third option is the patient may need referral for further treatment for the problem. So I want you to get in this mind frame. It's a different mind frame, but what are our possible nursing diagnoses based on our assessment findings? And what are some collaborative problems that we have to monitor and detect? And then possibly what are some other referrals we may need to do based on the assessment that we gathered. This concept of teamwork and interprofessional collaboration will be a concept that we will carry throughout the entire course and then some. Reporting abnormal findings is not something that I can just point to. It's a big exemplar within that concept. So we're going to talk one slide on this, and then throughout the entire course we'll be interweaving that throughout all of our assessments. So if there's any abnormal findings that you have identified, you as the nurse need to ensure that appropriate action is taken. So that action might be addressing that, probably will be addressing the problem within your scope of practice. It would be communicating findings to the healthcare team. Remember, this is the concept of interprofessional collaboration. So the healthcare team will be collaborating to manage whatever abnormal findings there are that have been identified. Documenting the findings so that the collaboration and communication is consistent. Change of shift report is the report where you have finished your time, whether it's a 7 a.m. to 3 p.m. shift and someone else is coming on at 3, you give them a shift report and collaborate appropriately within the team. Transfer or handoff report is if your client is leaving from whatever area you're working in to another area. We've talked about SBAR method and how that is a succinct way to give a verbal report on a patient. You may also be documenting written problem-oriented problem-orienting documentation in the medical records, such as SOAP, which stands for Subjective Objective Assessment Plan. PI is Problem, Intervention, and Evaluation. And then a DAR note is a focus charting that specifically looks at data, action, and response. So you might find yourself documenting in the medical record in this problem-oriented fashion. And you will also find yourself addressing the abnormal findings within the scope of your practice, within what your nursing scope allows you to do. And we'll be talking about abnormal findings throughout this course, but this is just one slide on that, the whole concept of teamwork and interprofessional collaboration and what you do when you find something that is abnormal. So let's review our learning objectives for this presentation. Hopefully, you can now assess for the presence of pain as a fifth vital sign using the cold spot technique. You can differentiate between the different types of pain assessment tools, and you know how to report abnormal findings. As usual, if you have any questions or need any more information, please feel free to reach out to me. Take good care.